Okay, welcome to my session today. Today on Surgery Clinics, we'll be discussing the problem of abdominal mass. Now, what is abdominal mass? By definition, an abdominal mass is any abnormal growth that occurs within the abdomen. And the abdomen can be divided into three parts: the anterior abdominal wall, also known as the pre-peritoneum, the peritoneal cavity proper, which is known as the intraperitoneal, and thirdly, the retroperitoneum behind. Okay, in this slide, it shows you the various peritoneal space, which is the anterior abdominal wall, the space in front of the abdomen. The second is the intraperitoneal. Okay, the second one here is the intraperitoneal, where the visceral peritoneum covers these organs within the peritoneal cavity proper. And the third one is the retroperitoneal space here, and this space is behind the attachment of all these organs within the peritoneum, right? And it lies in the space between the spine and the peritoneum. And this is the retroperitoneal space. Okay, and this is a transverse version. First is your pre-peritoneum, okay, in the anterior abdominal wall here. Then you have your intraperitoneal space, which is within the cavity of the abdomen proper. And third is the retroperitoneal space here. And in this case, it shows you the kidneys and the spine and the spinal muscles. These are all the structures that line the retroperitoneal organ. The visceral peritoneum coats all the organs within the peritoneal cavity, whereas the parietal peritoneum lines the wall of the peritoneal cavity. Okay, this first picture here shows you the peritoneal cavity. This peritoneal cavity, as I said, occupies the whole of the abdomen, and the important organs in this peritoneal cavity are liver, stomach, and intestines. Okay, these are the main organs that fill up the peritoneal cavity. And this peritoneum is lined by two layers of peritoneum: the visceral peritoneum, which lines the organs, and the parietal peritoneum, which lines the outer layer, which lines the whole of the abdominal cavity. And here in this picture, it shows you the retroperitoneal cavity. The retroperitoneal cavity is an important cavity because although it is not as spacious as the intraperitoneal cavity, it contains very important organs, especially the aorta and its branches, the vena cava and its tributaries that drain into it, the kidneys on either side. Then you have the second and third part of the duodenum, which is plastered by this peritoneum onto the peritoneal posterior abdominal wall, and the pancreas, the whole of the pancreas. Then lower down you have the iliac vessels, which come out from the aorta, and the bladder and uterus. Okay, these are all extraperitoneal or retroperitoneal cavity. Okay, for convenience, the abdomen can be divided into four large quadrants. Okay, here you've got a right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Okay, and each of these quadrants contain the various important organs within. In the right upper quadrant, the three main ones are the liver, stomach, and the gallbladder, and part of the duodenum. And in the left upper quadrant is the stomach, spleen, and the pancreas. The right lower quadrant, appendix, right colon, and right ovary in females. And in the left lower quadrant, you have the colonic diverticula and the left ovary in females. It also carries your descending and sigmoid colons in the lower abdominal, left lower quadrant. The kidneys, on the other hand, occupies both the upper and the right quadrants on either side, on the right and left. Okay, this slide shows you more detailed division of the abdominal. In this case, it is divided into 9 regions, and which are classified as upper, middle, and lower regions. The upper region consists of the right hypochondrial region, which contains the liver and the gallbladder basically. The middle is called the epigastric region, which houses the esophagus and the stomach and part of the duodenum. And the left hypochondrium is basically where the spleen and the part of the stomach is located. The middle group of region is the right lumbar, left lumbar, and umbilical. The right lumbar contains basically the right kidney and the ascending colon and cecum. The middle one consists of the umbilical region, stomach, and the pancreas. And the left lumbar region contains the kidney and the descending colon. The lower regions, on the right is the right iliac region, or the right iliac fossa, this is commonly called, left iliac region or left iliac fossa, and the middle is the hypogastric or suprapubic region, which contains the bladder, prostate, uterus, and ovary. The right iliac region is very important as it contains the appendix, the cecum, and the right ovary. Whereas the left iliac region or fossa consists the sigmoid colon and the rectosigmoid and the left ovary. And this sigmoid is very important as it is the site of the colonic diverticular, and it's a very important condition which must be recognized when the patient has pain in that region. Okay, the other important thing is to know the organ of origin of your abdominal mass. Okay, these are the number of conditions, the organs which can give rise to the various abdominal masses: liver, hepatoma; stomach, cancer; spleen, okay, splenomegaly; gallbladder, gallstone problems; kidneys; colon. On the right is yours, right colon, ascending colon, and cecum. On the left is the descending colon, sigmoid, and rectum. The small intestine, which occupies almost all of the quadrants, and the appendix, mainly in the right lower quadrant. Then you have the cecum, the pancreas, ovary, urinary bladder, uterus, abdominal wall, the anterior abdominal wall, and also the retroperitoneal soft tissue structures, which can give rise to soft tissue tumors. Now, what are the definite masses going by the organ of origin? In the liver, it can be due to liver abscess, hepatitis resulting in hepatomegaly, metastatic masses, and primary tumors, hepatoma or hepatocellular carcinoma. Okay, this can cause massive hepatomegaly and a mass in the upper outer quadrant. Then the stomach can give rise to lesions, masses, especially carcinoma of the stomach and gastric outlet obstruction leading to a massively dilated stomach, and sometimes it can also cause leiomyomas. Gallbladder, the tumors or the masses arising from the gallbladder may be due to empyema, in which case it would be tender, mucocele, carcinoma of the gallbladder, and the various bile duct cancers. Left colon, on the left side of the abdomen, is arising from the descending and rectosigmoid and rectum. The most common causes of masses from this region will be the carcinoma of the colon and diverticular masses. Okay, diverticulitis leading to diverticular masses. The right colon, the right iliac fossa region, is mainly due to appendicular mass, cecal mass of the cecum, and ascending colon. The kidney can give rise to masses due to obstruction and hydronephrosis, congenital polycystic kidneys, renal cell carcinoma, and in children, Wilms tumor are hypernephromas. Appendix can give rise to masses due to inflammation, appendicular mass, and abscess, which are one of the most common masses in practice. Ovary can give rise to ovarian cyst or carcinoma. Pancreas can give rise to congenital cysts, pseudocysts of the pancreas, and carcinoma. All these can give rise to various forms of masses. And massive splenomegaly is another cause of abdominal mass, especially in the left upper quadrant. And this is usually due to portal hypertension, thalassemias, and lymphomas. Okay, now how do you go about evaluating a patient with abdominal mass? First, as usual, history and symptoms. You must go through the onset of the swelling. You must describe the details, onset, acute onset, or insidious chronic onset, the site of the mass, size, shape, and surface. These are the important things you must know about the mass. Okay, it's chronic onset. Insidious chronic onset is usually can be a malignant lesion, whereas acute onset is unlikely to be a malignant lesion unless there is a complication of the malignancy, and it's usually due to infection or other inflammatory causes. Next, you go to tenderness, mobility, pulsation, and consistency of the mass. This is very important. Tenderness. A tender mass is usually not malignant, whereas non-tender mass is usually more, chances of malignancy is higher. Mobility is important to see whether it is intraperitoneal or retroperitoneal. Intraperitoneal masses are more mobile and they freely move with respiration. Whereas a pulsatile mass usually suggests some form of vascular dilatation, aneurysms. And consistency is another important factor. Okay, hard consistency usually suggests a malignant lesion, whereas soft or fluctuant consistency suggests it is a benign and cystic. Onset, as I said, acute or chronic, and the important thing is progress is important. Okay, whether the lump is growing in size, whether it is becoming more painful, and whether it is causing pressure symptoms. These are very important to be detected on history. Then is associated presenting features, especially fever, okay, suggest inflammatory or infection, pressure symptoms due to the symptoms depend on the pressure, on which organ the pressure is being applied. Loss of appetite, loss of weight, and generalized malaise, which are usually suggestive of malignancy. And lastly, symptoms related to the organ of origin. For example, if it is the biliary system, then you must look for symptoms related will be jaundice. If it is coming from the stomach, then we have epigastric pain or vomiting. Okay, so symptoms related to the organ of origin of the mass. Having gone through these details of this important history, which are very important, then you go to the examination to detect for signs of the lump. Okay, first as I said, mobility is very important. This is to be determined very carefully by detailed or careful palpation. Mobility in the vertical and transverse directions, and also its mobility to respiration. As I said, intra-abdominal masses, intraperitoneal masses are usually freely mobile with respiration as well as by palpation. Whereas retroperitoneal masses are usually immobile or with limited the mobility because they are clustered onto the posterior abdominal wall by the parietal peritoneum. Then to determine whether it's pulsatile is very important. Okay, as I said, a pulsatile mass suggests vascular origin. And the most common will be your aortic aneurysm or aneurysm of any smaller vessels as well. Whether together with this pulsatile mass, you have to also look for a bruit. A systolic bruit will suggest it is a vascular lesion. Next, we come to examination for us, whether it's a cyst or solid. This is also very important. A cyst is soft and fluctuant, whereas a solid is firm to hard and it is non-fluctuant. So this is important because cysts in general are benign lesions, whereas solid malignant lesions are usually solid in nature. Tenderness, guarding, and rebound tenderness are very important, especially if it is due to inflammation or infections. For example, due to acute appendicitis, a mass that is formed is usually tender with guarding and rebound. So is a mass arising from diverticulitis on the left side of the abdomen. Next, we come to skin changes. Okay, the skin changes over the lump, discoloration, inflammation, edema. These are all very important signs that must be detected and reported by the student. Next, we come to special signs. For example, Murphy sign for acute cholecystitis and psoas sign in patients with acute appendicitis. Last but not least is percussion and auscultation. Very important. Percussion can help you to determine whether it is contains the lump mass contains air. Then it is most probably due to a bowel, distended bowel. And auscultation can help you to determine whether there is a bruit or increase or decrease bowel sounds in the abdomen. Okay, now then there are some special considerations that must be taken into account. Okay, intraperitoneal masses, as I said, usually freely mobile with palpation as well as respiration. Retroperitoneal masses, on the other hand, are immobile or limited mobility, and I explained the reason for this as well. Next, we come to the abdominal wall masses, and these will, especially the anterior abdominal masses, wall masses arising from the wall of the anterior abdominal wall, will diminish with tensing of the abdominal muscles. So ask the patient to tense his muscles and the lumps will become less prominent. And cysts versus solid, very important. Cysts are usually dull but fluctuant, often benign. Solids are usually dull on percussion and have a higher risk of malignancy. The last one is your pelvic mass, which is also in an extraperitoneal region. And classically, the masses from pelvis arise deep inside the pelvis. And therefore, on palpation, you will not be able to get below the mass. Okay, so these are classically pelvic masses, such as uterine masses, bladder masses. Okay, this you cannot get below. The lower border cannot be determined. Okay, now what are the common abdominal masses that we normally see in patients? As I said, one of the most common is arising from the appendix due to acute inflammation. Is an appendicular mass or an abscess. Okay, so initially it forms an abscess and later is sealed off by the small intestine and omentum to form an appendicular mass. And this is classically located in the right lower quadrant. Next, we have ovarian masses in female patients. This is another important cause of abdominal mass. It can be either on the right or left side. Cecal masses usually carcinoma of the cecum, also in the right lower quadrant. Carcinoma of the rectal sigmoid region, usually in the left ilia fossa. Okay, left ilia fossa mass. Carcinoma of the stomach, normally in the epigastric mass. Then from the uterus, you can have fibroid and ovarian mass, which I've already mentioned. And usually uterine masses are usually suprapubic in location. Then you have liver masses, tumor, abscesses, or massive hepatomegaly, renal tumors, and hydronephrosis. So, common cause of hydronephrosis used to be obstruction due to stones. Then you have aortic aneurysm, is mainly more on the left side of the abdomen, slightly to the left of midline, and is usually due to abdominal aortic aneurysm. So these aneurysms are usually pulsatile in nature. So this can be, and they also may have a systolic bruit over them. Next we come to pancreatic masses, cysts, especially pseudocysts of the pancreas resulting from acute pancreatitis. And more important is a tumor of the pancreas. Especially the most common would be the head of the pancreas. And these patients with tumor of the head of the pancreas will be present with obstructive jaundice. Then you have the urinary bladder, okay, especially in older men with BPH and acute retention of urine. When they come in, they will have a palpable bladder, large mass in the suprapubic region. Okay, so and this can be either tender or non-tender depending on how rapidly the obstruction has taken place. Again, these urinary bladder masses, enlarged bladder, you will not be able, classically, you cannot get above it, below it, and also on percussion, it will be dull and cystic. And lastly, we come to retroperitoneal soft tissue tumors. And as I said, apart from the major organs in the retroperitoneal area, it also consists of soft tissues like muscles, and tumors from these tissues can arise, retroperitoneal soft tissue tumors. Okay, having taken a history and a proper thorough physical examination, you more or less come to a provisional diagnosis. And with this diagnosis, then we go ahead to carry out some investigations to confirm or exclude your diagnosis. And the investigations include blood investigation, which can be routine, especially for elderly patients, or can be specific, such as if you suspect it is a tumor in the bowel, colon carcinoma, you'll do for CEA levels or CA 19-9. Okay, these are important for tumor markers for the various tumors that you may see. Next, you come to urine analysis, looking for leukocytosis, RBC in the urine, and cytology for malignant cells. The next important group of investigations are known as the imaging investigations, among which include X-rays, plain X-rays, especially plain X-ray of the abdomen, ultrasound scans of the abdomen and pelvis, which can decide whether to go on to CT scan, MRI, and endoscopy. Okay, so these are all important investigations for a patient with presenting with an abdominal mass. And usually we do the simplest one first and then go up to do more sophisticated investigations. And the final diagnosis is you need a tissue biopsy from the mass. Okay, nowadays there are a number of methods that can be done, and these are usually done under ultrasound and or CT scan guidance. Okay, that will give you more accurately the diagnosis from the tissues obtained from the organ of origin. And then you also have endoscopic biopsies such as EUS, endoscopic ultrasonic biopsies, or through endoscopes, OGDS, and colonoscopy with biopsy. So these are biopsy will give you the definitive diagnosis in particular patient. Other investigations include ERCP, special imaging, especially radioisotope imaging. So these are done as and when necessary from the earlier imaging investigations that you carry out. Okay, in the abdominal, as far as in investigation of a patient with abdominal mass, imaging is become a very important and useful method. Among them, you have got the abdominal X-ray, a plain X-ray of the abdomen done supine and erect if necessary. Secondly, you have the abdominal ultrasound, okay, which is the most standard investigations is done these days. Sometimes, if necessary, you may proceed on to do an endoscopic ultrasound. The third one is a CT scan. It's a very important investigation, and usually it is the contrast enhanced CT scan, and sometimes a CT angiogram may be needed if vascular lesions are involved. And the other one is not, which is often sometimes done, is your magnetic resonance imaging or MRI. So these are the important investigations you must all, especially the first three, which you must be very familiar with in the case of abdominal masses. Okay, this X-ray shows you a plain X-ray of the abdomen here. This is a normal X-ray, normal plain X-ray. You can see here. These are the various parts that are being labeled. So you must be very familiar to identify these landmarks in a plain X-ray. Okay, here you can see an abdominal X-ray showing you a large mass here. Okay, a large mass indicated by the arrows on the right side, occupying the whole of the lumbar region and probably extending into the iliac region as well. The mass is heterogeneous in consistency, as you can see here, and with the rim of calcification, okay, and the arrows point to the margins of these borders of this mass here. Okay, it can be a appendicular mass, can be a cecal mass, or ovarian mass, whatever it is located in the right lower quadrant. And here, this is another plain X-ray showing you a large left-sided mass here, which is probably coming from the kidney, enlarged left kidney. And in this patient, it is an Wilms tumor, and this is in a child. Okay, CT scan. This is a CT scan showing you a pseudocytosis of the CT scan of the pancreatic pseudocyst, the large cyst here. Okay, originating from the pancreas. You can see it is quite separate from the left kidney here. Okay, and here a large mass in the right flank here, the whole of the abdomen. This is a patient as a child, and this is a case of nephroblastoma. And this shows you a large mass in the center of the abdomen, and this is a mass coming from the mesentery. It's called a mesenteric mass. Okay, now I'll go through some pictures of abdominal masses of the various types that we commonly see in our practice. Okay, this is a young man with a mass. He clinically presented with acute appendicitis and with a mass, tender mass in the right iliac fossa here. Okay, so you can see there are no skin changes. The measurement is around 4 by 3 centimeters in diameter, and classically it is tender and guarded. So this is a appendicular mass or abscess. Here you have got a large mass here. Okay, you've got a very large mass here, which suggests in the epigastric region. And this is a patient who looks emaciated, is carcinoma of the stomach. Again here, another patient with a right iliac fossa mass. It's an appendicular abscess with tender, guarding, and mass in the right iliac fossa. Then you got this patient with a large cystic swelling over the epigastric region. And this patient had acute pancreatitis and complicated by a pseudocyst of the pancreas. Okay, and in these cases, the patients will have the lumps will be mildly tender and fluctuant and dull on percussion. And here is a large mass in the right iliac fossa region, very vague and diffuse, and this is non-tender and mobile. So this is a patient with carcinoma of the cecum. This is another patient, large mass in the right iliac fossa, which can be used to appendicular mass or CA cecum. A good history and examination may be necessary to determine the nature of the swelling, followed by investigations like ultrasound and CT scan. Okay, now we go through some questions related to abdominal masses. So as you go through these questions, you read the questions, pause the video, and answer the questions yourself before replaying to see the answers. Okay, a 22-year-old female patient complained of right iliac fossa pain for 5 days. It was associated with vomiting and fever. Examination, the temperature was 38.6 degrees Celsius and the heart rate 100 per minute. There was a mass at the right iliac fossa with tenderness and guarding. Okay, here. What is the possible diagnosis of this mass? The answer is appendicular abscess. Question number 2. Name 3 differential diagnoses for this patient. The answer, acute appendicular mass, ovarian cyst, and mesenteric lymphadenitis. Question C. Name the imaging investigations for her. Imaging investigations are ultrasound abdomen and pelvis and CT scan of the abdomen and pelvis. Question number 2. A 62-year-old woman presents with a mass in the left iliac fossa for 1 month, associated with blood-stained stools off and on. Examination reveals a non-tender mass 4 by 5 centimeters in the left iliac fossa and it is mobile. And what is the most common likely diagnosis of this patient? The answer is carcinoma of the colon, sigmoid colon or rectosigmoid colon. Okay, this will be the most commonly diagnosis in this patient, considering the age with blood-stained stools and a mass, non-tender mass in the left iliac fossa. Question number 2. Name 3 differential diagnoses. These are carcinoma descending colon, diverticulitis with the diverticular mass, and ovarian cyst, left ovarian cyst. Question C. Most useful diagnostic investigations for the patient. This will be colonoscopy and biopsy. Question number 3. The 72-year-old man complained of a painless mass in the left side of the abdomen for the last 6 months as shown in the arrow. It was pulsatile and immobile with no tenderness or guarding over it. What is the most likely diagnosis? Abdominal aortic aneurysm, AAA. What investigations will you do for them? Ultrasound abdomen and CT scan if necessary. Question C. What are its complications? These are thrombosis of the aneurysm, rupture of the aneurysm, pressure on adjacent organs, and embolism. Embolic phenomena, embolism from the aortic aneurysm. Very important in aneurysm to examine the patient to see whether the pulsation is expansile or pulsatile. Okay, arterial aneurysms usually have an expansile lump, and this can be detected on palpation. Whereas pulsatile sometimes can be transmitted by an overlying mass, a lump that lies over an aneurysm. Case number 4, a 92-year-old woman presented with a non-tender suprapubic mass that was resonant to percussion. She was otherwise asymptomatic and denied any urinary symptoms. What is the cause of this mass? Distended bladder, okay, resulting from some form of obstruction to the bladder neck. How will you confirm this? And this can be confirmed clinically by palpation and percussion, and classically it will be dull in nature and cannot get below the lump. Okay, you cannot get below because it comes from the bladder, which is a pelvic organ. Okay, you can see the mass, well-defined mass here, suprapubic region. It is very interesting that in this patient, it was a pneumobladder. That means a bladder containing air. How does air get into this bladder? In this patient, the CT scan showed a colovesical fistula caused by diverticular disease. So acute diverticular disease causes a colovesical fistula, thereby the bladder is filled with air instead of urine, and so it is resonant to percussion. This is a very rare cause which you may not be able to detect in patients if you do not suspect them. We come to the end of this session. Thank you very much for joining me and hope to see you again in another session.